Niacin is one of those supplements where the internet sounds weirdly confident. It raises HDL, lowers triglycerides, therefore it protects the heart. Is that a fair shortcut, or are we mixing up a vitamin need with a drug level effect?
That shortcut is the whole lesson. Vitamin B3 is a family. Nicotinic acid, often called niacin, nicotinamide, also called niacinamide, and newer NAD precursors like NR and NMN. They all connect to NAD chemistry, but they do not behave identically in the body. Nicotinic acid is the classic lipid-altering form and the classic flushing form. Nicotinamide is usually less flushing, but it is not the same cholesterol drug.
So, if someone eats enough B3, what are they actually supporting? And when does the conversation stop being nutrition and start being pharmacology?
At nutritional levels, B3 is raw material for NAD and related cofactors. Think of NAD as a reusable electron shuttle and enzyme helper in energy metabolism, DNA repair signaling, and many cell stress pathways. If intake is too low, the benefit of restoring B3 is basic. You prevent or correct deficiency physiology. But if someone is already replete, extra B3 does not automatically translate into more energy, better arteries, or longer life. Baseline context matters more than the bottle. Niacin comes from foods like meats, fish, grains, and dairy, and the body can also make some from tryptophan. Deficiency risk rises when diets are limited or when staple foods provide poorly available niacin, such as maize without preparation that improves bioavailability. In that setting, B3 is not a hack. It is essential nutrition.
The lactation study is interesting because supplementation clearly moved milk vitamin B3 levels. But did higher milk B3 actually show up as better infant growth or development?
Exactly. In that trial, 250 milligrams per day of nicotinamide raised human milk total vitamin B3 by roughly 291% at month 1 and 281% at month 5 versus placebo. It also reduced the share of low milk B3 values. But the investigators did not find associations with infant weight, height, head circumference, or developmental scores up to 18 months. So it proves exposure changed. It does not prove a visible child outcome changed.
Okay, back to cholesterol. If nicotinic acid can improve a lipid panel, why not just use it to push HDL up and triglycerides down?
Because the endpoint is not a prettier lipid panel. It is fewer heart attacks, strokes, procedures, or deaths. Niacin became popular because it can shift lipid biomarkers, especially at high doses. But modern prevention usually prioritizes therapies with stronger outcome evidence and known risk-benefit profiles. If niacin is being considered for cholesterol now, that is a clinician-level decision, not a self-experiment based on HDL marketing. And the form matters for side effects. Oral niacin and nicotinamide have been associated with gastrointestinal upset, skin rash, fatigue, flushing or vasodilation, and liver dysfunction. Reviews suggest nicotinamide tends to have fewer adverse effects than nicotinic acid, but higher doses raise the odds of trouble. That is why supplement labels can be misleading if they hide the form or dose behind the same word, B3.
A lot of B3 marketing has moved from cholesterol to NAD and anti-aging. If NR and NMN raise NAD markers, is that a stronger case than old-school niacin?
It is stronger for one narrow claim. Some NAD precursors can raise NAD-related metabolites in humans. A 2026 systematic review found oral NR and NMN generally well tolerated over weeks to months and consistently showed biochemical target engagement. But functional, metabolic, vascular, and other health span relevant outcomes were heterogeneous and often null. 4.4 or IM NAD wellness claims. The review found no eligible outcomes trials.
One human study compared nicotinamide, NR, and NMN. Did it suggest these boosters work through the gut rather than simply slipping straight into blood cells?
Yes, and that makes product claims trickier. In 65 healthy participants, 14 days of NR and NMN comparably increased circulating NAD, while nicotinamide did not show the same chronic effect. The authors also found ex vivo evidence that NR and NMN can give rise to nicotinic acid through human microbiota, and that nicotinic acid was a potent NAD booster in whole blood. Translation: the label ingredient may not be the final active route. There are also niche medical contexts, but they do not generalize to wellness use. In hemodialysis patients with high phosphate, niacinamide 250 to 500 milligrams per day lowered serum phosphate in a small randomized crossover trial, with 3 dropouts due to side effects. That is interesting, but kidney failure is exactly the kind of context where dosing belongs with the renal team, not a consumer experiment.
If someone is still considering B3, what should they measure or ask before buying it? Is there a simple rule for when expectations should change?
Use a 3-box test. Box 1. Are you correcting a plausible intake gap? Then food pattern or a standard multivitamin level product may be enough. Box 2. Are you trying to treat cholesterol, phosphate, glaucoma risk, skin cancer risk, or another condition? Bring that to a clinician because the doses, endpoints, and monitoring change. Box 3. Is the promise anti-aging or general energy? Then NAD biomarkers are not the same as feeling or living better. High-dose niacin can flush, upset the gut, affect the liver, shift glucose, and interact with medications. So the safest interpretation is respectful skepticism.